So we can now start. This is, can you see the slide? Can you see the slides?
Yes, sir, we can see them.
What's written there?
It's written in the material file of reality free images.
Okay, so let me just, I want to bring out today's presentation slide. So when we get there, then we proceed. Okay, so assisted reproductive techniques, also called ART. Introduction. So when we say a woman of reproductive age who has not conceived after 1 year of unprotected vaginal sexual intercourse, in the absence of any known cause of infertility, that woman should be offered further clinical assessment. So a gynecologist have to clinically assess the woman and find out why the husband is pouring into the lagoon, but still she is not conceiving or becoming pregnant. So we have to offer an earlier referral specialist, consultant, or a gynecologist to discuss the options for attempting conception. So what she has done, you know, the lecture 5 was on working up infertility issues. So how do we solve infertility issues? So we end up giving some estrogen, progesterone hormones. We end up also counseling the woman, even teaching them how to do sexual positions. Some of the styles, like the woman will put the head down and the legs will be up. How can the sperm enter the woman's vagina and enter the cervix and swim, overcome the cervical mucus plug? So there are special ways of you becoming pregnant. It's not every sexual style that would lead to pregnancy. So the woman is also should also not be more than 36 years old, and also if there is a clinical cause of infertility, the history regarding the infertility issue. So is the woman having polycystic ovarian syndrome? Is the woman having amenorrhea? So the amenorrhea means that absence of what? Menses or menstrual flow. So all this, the medical doctor or the gynecologist has to assess the woman. Then if it's and he has to assess the woman and even assess the man too. If it's serious, then he will refer the man to a urologist. If the situation is serious, then you have to refer the woman, the man also, to a urologist. Urologists are doctors, specialists who attend to male issues. Urologists, they attend to male issues. So issues bordering about the male reproductive system is handled by a urologist. Okay, so these are the main causes of infertility. 1. 34% is caused by the male. Like if the male has low sperm count, it will contribute towards infertility issues. Because normally every male is supposed to have significant amount of, or is supposed to produce optimum or normal concentration, normal level of testosterone. Testosterone, is that the hair? Then luteinizing hormone. A male is also supposed to have normal levels of what? The androgens, testosterone, luteinizing, and also follicle stimulating hormone. So if the male is not producing these hormones, or in case the male has testicular cancer, or this same male, in case he has what do we call it, testicular cancer, that one you have to assess it using testicular biopsy. We take a tissue, small section of the testes, the tissues of the testes, and study whether there is cancer there. So you have to do all this. Then you have to also do the sperm count. Sperm count, to look at the morphology of the sperm and also the integrity of the sperm. So the male factors have been spelled out here. I've spelled out the male factors over here. So upon consulting a urologist, the male can have his infertility situation worked up for him. Okay, so let's also see other causes of infertility. Cervical causes. That is the woman having cervical cancer? Cervical cancer. We finish with the male, so I can delete it. So is the woman having cervical cancer? Cervical cancer. So cervical cancer is predisposed to most of the infertility situations in women. There can also be, apart from the cervical issues or cervical cancer issues, we also have 11% of infertility being contributed by uterine factors relating to the uterus. So we finish with cervical. So we go to uterine factors. And the women's issues are handled by gynecologists. So the cervical uterine factors, let's look at uterine factors. So for uterine factors, we have let's see, one. Uterine factors, we can have endometrial, we have endometrial polyps. There is also endometritis. Endometritis, anytime you see a word ending with the suffix itis, it means inflammation, inflammation, or sores created due to what? Infection. So you look at infection. So we have endometritis, then endometrioma or endometriosis. This is the migration of the endometrium into other locations apart from the womb. So endometrial tissue will move from the endometrium and go and implant on the ovaries, or go and implant on the cervix, or go and even implant on the liver. That is what we call endometriosis. Then we also have leiomyomata. That is plural. These are fibroids. Fibroids. So there are some fibroids, if you have them, you can give birth. Others too, if you have them, you cannot give birth, because if the fibroid is rooted inside the endometrium, it will prevent implantation of the blastocyst. So it will be difficult for such a person, a woman, to give birth or to conceive. But those which are subserosal or perimetrium, the fibroid is implanted in the perimetrial tissue or the serosal tissue, has no effect. The woman can have fibroid, but she can give birth to all her children. Then there is also one inside the myometrium. If it doesn't affect significant contraction of the uterus, then such a woman can also give birth. And there are a lot of issues which such women have delivered before. We also look at, we have looked at endometrial, then there is also endometrial CA. Whenever you see CA, it's cancer. That's an abbreviation, endometrial CA. Anytime you see CA, it's cancer. The doctors want to just bully us with some of their abbreviations. So endometrial CA. So these are some of the causes of uterine causes of what? Infertility. So let me share those slides with you so that you see the pictures of what I'm talking about. So let's go and you see the pictures. Let me admit these people. You see the pictures of what I'm talking about. So let's see. So we have endometrial polyps. So you can see a polyp, that's a swelling, a swelling which is attached to the endometrium. You can see one is here. Can you see it? Can you see? Hello?
Yes, sir.
Okay, so you can see endometrial polyp here. So if there is a polyp, if you have endometrial polyp, it's very difficult for you to have implantation because it's blocking the baby from having nourishment or being implanted into the endometrium. So it's difficult for such women to conceive. So we also have those with what? So then we have endometritis. You can see this picture. That is inflammation. Inflammation of the endometrial tissue. Inflammation is caused by infection. So if somebody has uterine infection, endometrial infection, then this is what is happening. So some women have PID that can even travel into the endometrium, pelvic inflammatory disease, that can travel into the endometrium. Some have rubella, syphilis, and others. That's why when you are pregnant, they tell you that you do the touchy screen. You screen for STIs, you screen for chlamydia and the rest. And these are infections that can cause infertility issues. Or even if you conceive, it will bring about abnormalities in the developing fetus. Let's go and see, and endometritis is still here. Let's go and see, this is endometrial cancer. You can see cancer is when the normal cells lose their apoptotic mechanisms. So when they are supposed to die, they don't die. And they become metastatic, meaning that they move from where they are and disseminate into the blood, that's systemic, and other organs. So that is what we call metastasis. Metastasis, yes. It will metastasize into other organs and others. So you can see the endometrial tissue has become reddened with blood vessels which are nourishing the cancer cells. So women like this, you just need to remove the whole uterus and throw it away. When you remove the whole uterus, you have to go and do histopathology to find out whether it is really a malignant lesion. And if it's a malignant lesion, the doctors they will just remove the uterus and go and do histopathology. If it's cancer, then they start treating the cancer. So every small thing that happens to your wife, make sure that quickly you rush to the hospital, because women are very delicate. So let's look at the leiomyomas, or the fibroid. Anytime you hear myoma, let's look at the spelling well. So myoma, most of the time they leave it as M-Y-O-M-A-S, myoma. But if it's plural, then you make it leiomyoma or leiomyomatus. So you can see all these things are fibroid. So I was telling you that if the fibroid, this is somebody's womb, it has a lot of nodules, fibroid nodules, nodulated with a lot of fibroid nodules. So you can see the types of fibroids that we have. We have the pedunculated abdominal fibroid. We also have submucosa. It's just lying under or within the endometrial tissue. Then we have the intramural, which is inside the myometrium. Then we also have, this is the ovary, the fimbriae are here. We have subserosa. That subserosa is the perimetrium, that's the outermost layer of the uterus. So you can see a subserosa myoma. So if somebody has subserosa myoma, don't worry yourself. Such a person will definitely conceive and be able to give birth, because it hasn't gotten any connection with the uterine lining or the endometrium. But if it is inside, if it is submucosa like this, within the endometrium, it becomes a problem. If it is intramural, it may cause problem or not, because it can cause problems with contractions of the uterus during labor, but it's not so significant like something, a fibroid that is within the endometrium or submucosa. So this is an example of a fibroid. This is also an example of a fibroid. So we can see interstitial fibroid, submucosa fibroid. The submucosa fibroid is very, very serious. We have different types of the fibroid here. Another one, fibroid tumors may occur in various regions of the uterus. So you can see them. Okay. Then let's go and look at endometrioma or endometriosis. Endometriosis, where is it? Endometriosis. Wow. Endometriosis is here. Very interesting. So for endometriosis, this endometrial tissue, the endometrial tissue lying here, the tissues will leave. Some parts of the tissue will leave and go and attach to the fallopian tube, or even go and attach to the ovary, or even go and attach to the ampulla. So you can see this is endometrial tissue. Instead of it to be inside the uterus or in the endometrium, so that it can nourish the blastocyst or the fetus, the endometrial tissue is moving around, taking visa to America, Canada, Ukraine, where you are not needed. So some can even travel and go and attach to the liver and other vital organs like the kidney. So this is supposed to support the fetus, but it is now going about traveling all around. And this is the condition we call endometriosis. It's a serious condition. Okay, so let's go back to our lecture slides. Yes. Hello. Hello. So we finished the uterine factors, which contribute to about 11%. So we have the tubal factors. So the tubal factors is that is the woman's fallopian tube blocked? So we are on the tubal factors. Tubal. Is the woman having a blockage in her fallopian tubes? So that is blockage of fallopian tubes, or fallopian or uterine tubes. And so there is a medical procedure that is done that we call it salping. Anytime you hear salpings, is the fallopian tube. So salpingostomy, and another one is salpingectomy. This one you drain the content, and the gectomy you create a hole inside the fallopian tube, because the fallopian tube is blocked. There is no patency. There is no patency. There is no hole for the sperm to travel through. There should be a hole or a pavement, a path, so that the sperm can travel through. So that is what we call patency, or hole, for the sperm to travel through. So if there is no patency, if there is no patency, it becomes difficult for the sperm to travel through. So they have to conduct a procedure and drain the content of the fallopian tube, and that is what we call salpingostomy. And also salpingectomy, that one they just create a hole inside it. So this is what happens. Then let's look at, so we finish with the fallopian tube or tubal factors. So let's look at the next factors. The next factors is hormonal factors. Hormonal factors. And this one is very, very serious. Hormonal factors. Because some of the young ladies who are around, do you know what they do? Small time, they will go and buy Lydia. Or Postinor 2. And these drugs cause imbalances. They cause hormonal imbalances. They cause hormonal imbalances. And the hormones that they cause imbalances are estrogen and progesterone. So you can see that a woman will be there, she will come to the scan center or the hospital, say, I don't have, for about 5 months now, I have not menstruated. And even when I menstruate, it's not regular. It's because of the emergency, and this Postinor 2 and Lydia are called emergency contraceptives. Emergency. And they are supposed to work within 72 hours. Emergency contraceptives. So, and they create a whole lot of infertility issues. Because after killing the sperm inside the vagina, what did they do? They cause hormonal imbalances. Imbalances in progesterone and estrogen level will cause desquamation or the shedding off of the endometrial tissue. They will cause desquamation or shedding off of the endometrial tissues. So some of them will be bleeding. For a long time they will be bleeding. It's because of the Postinor 2. Imbalance in estrogen and progesterone level. Some of them too, they will not be bleeding, but they will be what? Irregular menses. Some too will have amenorrhea. which is also called absence of menses or menstruation. So women, when the man tells you that go and buy, if the man go and buy Postinor 2, that you should use it to kill his child for him, don't mind him. Did you hear me? Don't mind him,
Yes, we have heard you.
They will tell you, kill the child. Later they will tell you that you are barren. They will tell you are barren.
Sir, a question.
Not now, Abba. Okay, you ask.
Is it not a contraceptive?
It's an emergency. You know, contraceptives, we have 1 month, we have 2 years one, 3 months one, this. And all the contraceptives cause imbalances in progesterone and estrogen level. You know, the contraceptives,
okay.
the contraceptives themselves, can you hear me?
Yes, please.
The contraceptives themselves are being made or synthesized with estrogen and progesterone. So we have progesterone contraceptives, estrogen contraceptives, and we have a combination of progesterone and estrogen contraceptives. You understand? But your ovaries are producing estrogen and progesterone. So you don't need that synthetic one, because the synthetic one, when they come, they will inhibit the gonadotropic releasing hormone, which will cause follicle stimulating hormone and luteinizing hormone levels to be inhibited. And this one will lead to anovulation or absence of ovulation. That is what causes the menstrual flow to cease. So a woman will be there and say, 6 months I have not menstruated. If it even comes, I will just be spotting. It will just come small, and it will go. So these are emergency contraceptives. So if you want to pass somewhere, professionally, go for condom.
Oh, use condom.
Use condom. Or coitus interruptus, when it's coming, remove it and throw it somewhere.
That one is difficult.
Please, I'm a pastor, but I'm teaching you professional something. So whatever I tell you is your life. The coitus interruptus, you continue doing it, you will see what will happen to your heart. The thing is coming and it's shaking, gaga, and you remove it and throw it somewhere, and your heart is beating, ka. And then, my bro, let's continue. So I've finished with the hormonal imbalances. So let's continue with so assisted reproductive techniques. As reproductive techniques, we have is any treatment that deals with or means of conception other than vaginal intercourse. So some of the time, it's not possible to give birth through the natural way, that's the vagina, the penis penetrating the vagina to make the woman pregnant. It's not possible. Or maybe the woman has a whole lot of problems, imbalances, hormonal imbalances, tuber fat, other things. So you need to fertilize the egg or do in vitro fertilization outside the uterus. Then go and implant it inside the uterus. So if you are going to go by this, we have 3 ways. We have more than 3, but these are the 3 important ones that your syllabus say I should teach you. We have the intrauterine insemination. We have the husband donating the sperm, or maybe if the husband is azoospermia and cannot donate the sperm, then we go and buy the sperm from a sperm bank and come and insert the sperm into the woman's uterus, identify the fallopian tube where the egg is, harvest the egg, and put it inside the ampullar region so that it will directly go and fertilize the egg. But with the in vitro fertilization and embryo transfer, you do it outside. You do the fertilization The previous one deals with you fertilizing inside the uterus, but you have to help the sperm because some of the sperms are weak. They cannot cross the cervical mucus plug, and the cervix has some mucus there. We call it cervical mucus. Cervical mucus plug. You know, the cervix has to be closed. It has to be closed by a plug, so that infection will not enter through the cervix and go and affect the woman. So that is why we have cervical mucus plug. So we have cervical mucus plug that is protecting the cervix, the hole inside the cervix. You know, the hole inside the cervix, we have the internal cervical os and external cervical os. Whenever you see os, it's what? A hole. Os means hole. So the internal cervical os is a hole that enters the uterus, the uterine cavity, whereas the external cervical os enters the vagina, knowing that the cervix is like a cylinder, and the inside one enters the uterus, then the outside one enters the vagina. So we have the cervical mucus plug. So some of the sperms, if they are weak, they cannot swim towards the cervical mucus, across the cervical mucus plug to the fallopian tube to go and fertilize the ova or the egg. Some of the sperm too, you know, the vagina has an acid level, or the vagina is acidic. So the vaginal juice is acidic. So because it's acidic, it's able to protect the woman from infection, her womanhood, vagina from infection. It's able to protect the woman's vagina from a lot of infection. You know?
Sir.
Yes.
Is it vagina fluid or juice?
Vagina what? The juice is the same as fluid, eh? It's the same as fluid. But you have been seeing it.
Yeah.
You are familiar with it, but so it's acidic, because if it's not acidic, a whole lot of organisms will be there and they will cause problems. So we have a lot of lactobacilli there causing acidity. They are commensals, commensals. They are intestinal parasites in the intestines, and also the vaginal side we have vaginal acidity, and it's supposed to kill germs in the vagina so that they will not affect the woman and cause endometritis. So that's why God put it there. So the woman is such a wonderful person with a lot of acid in her vagina to kill pathogens or disease-causing organisms. So let's continue. Let me connect some people who are standing outside and come and continue. Okay, I guess you can see the slide.
Yes, please.
Okay, so I've finished talking about the intrauterine insemination. So you have to help the sperm so that you can carry it to the egg, so that it will bypass the cervical mucus plug. It will bypass the cervical mucus plug, and also it will bypass the vaginal acidity. So that's why we do the intrauterine insemination. You harvest the sperm, or you take, if the man is azoospermia and cannot produce sperms, then you go and look for a donor to bring a sperm. Then we insert the sperm inside the woman's fallopian tube so that the woman will be pregnant. IVF, for IVF, That one, you harvest the woman's egg. And the egg, you can harvest it by a process we call ovulation, ovulation stimulation. And you need to stimulate ovulation by force, because some of the women, they have anovulation, they are not ovulating. Anovulation. So you need to trigger ovulation or stimulate ovulation. Stimulate ovulation. So in order to stimulate ovulation, we have a lot of drugs that we use to stimulate ovulation. The drugs for stimulating ovulation are, I'm just going to list them here. The drugs are: 1, clomiphene. Clomiphene, we call it clomid. Oh, clomid. If the woman is not ovulating, there is a drug that we can use, and clomid is one of them. We also have serophene. Serophene. You don't need these things, but I just want your mind to be very broad. We also have estrogen analogs such as desogestrel, ethinyl-diol. There are many, but I'll just list a few. Non-ethindrone acetate. So these ones are the estrogen. The clomid and serophene are not estrogen derivatives. These ones are not estrogen derivatives. But I'm putting estrogen just small. So these ones are estrogen derivatives. Estrogen derivatives. So estrogen derivatives. So estrogen derivatives are here. Okay. So these ones are, so estrogen derivatives, let me just put them in comma separation. Okay, so these are estrogen. Then let's go to progesterone. We have progesterone, we have the middle medroxyprogesterone. So it's supposed to stimulate ovulation. Norethindrone. Then last one, cyclic progestin. So these drugs are supposed to induce ovulation. So women, they don't have a problem. If you see a woman is not giving birth, is not even giving menstruating, or is not ovulating, ovulation is supposed to cause what? Activate the follicular phase, so that when the follicular phase is activated in the 14th day, there will be the production of what? The egg. And that is what we call the unsafe period. But if the woman is not going through those things, then these drugs are there that can force her to ovulate. Clomid is there, serophene is there, desogestrel, ethinyl-diol, norethindrone acetate. They are these three, desogestrel up to norethindrone acetate. They are estrogen. They are estrogen derivatives. And the medroxyprogesterone up to cyclic progestin, they are progesterone derivatives. They will force the woman to produce the egg. Okay. So when the woman is forced to produce the egg, then there will be what? They will harvest the man's sperms also. And most of the time, the IVF situations they use it to solve oligospermia, that's low sperm count. But if the man is not producing any sperm at all, then they will use a process called intracytoplasmic sperm injection. And intracytoplasmic sperm injection is for intracytoplasmic sperm injection. Intracytoplasmic sperm injection is for azoospermia, absence of sperms at all. If the woman is not producing sperms at all, we use if the man is not producing sperms at all, we use intracytoplasmic sperm injection. So we are going to start with the intrauterine insemination. Let's watch a short video on intrauterine insemination.
The menstrual cycle of fertile women usually lasts about a month. During this time, and under the influence of the body's own natural hormones, a tiny sac within the ovary The menstrual cycle of fertile women usually lasts about a month. During this time, and under the influence of the body's own natural hormones, a tiny sac within the ovary containing an egg grows to about the size of a grape. At a point midway in the cycle, this egg is released from the ovary and ovulation occurs. Ovulation is also regulated by hormones. The egg, which from this moment on is ready for fertilization, then passes into the uterine tubes to await the arrival of fertile sperm. Ovulation is a naturally occurring event, and the desire to have children is a similarly natural instinct. But that instinct cannot always be fulfilled. The causes of unwanted childlessness are numerous, but so are the means of treating them. With the technique of intrauterine insemination, sperm is provided either by the male partner or by a third-party donor whose sperm has been stored in a deep-freeze sperm bank. Before insemination, the sperm samples are prepared in the laboratory. They are assessed for safety, quality, and quantity, and then passed through a filtering system for grading and washing. With a syringe and fine tube, the prepared sperm cells are then introduced directly into the cavity of the uterus, beyond the mouth of the womb and the cervix. They immediately make their own way towards the uterine tube. The objective of IUI is to bring these sperm cells as near as possible to the egg. Nevertheless, only the most mobile sperm cells will actually reach the egg, and only one will penetrate the outer layer of the egg to achieve fertilization. But just as in everyday life, there are many times that fertilization fails and the cycle passes without a pregnancy. All these methods of assisted reproduction offer couples a good chance of bringing a healthy baby into the world. A consultation and thorough examination are necessary for each individual patient for finding the most appropriate treatment with the highest chance of success. Because female fertility decreases quite quickly after the age of 35, infertile couples should not delay seeking appropriate medical advice.
Okay, so we are back. We've seen intrauterine insemination. Okay, so let's go into intrauterine insemination. So intrauterine insemination is the injection of washed